Hi, my name is Billy Weinshank. I'm the Emergency Management Administrator for the City of Port St. Lucie. We're sitting here today with Dr. Mark Pamer to discuss COVID-19, most specifically the COVID-19 variant, the Delta variant, and talk a little bit about vaccinations and the science surrounding what has gotten to us to this point today.
I'm a pulmonologist here in St. Lucie West area, and just to tell you a little bit about myself, I went to medical school locally at Nova Southeastern University, and I did my residency at University of Florida Shands in Jacksonville, pulmonary critical care fellowship at Rush University Medical Center in Chicago. I was co-author of the initial paper that linked gastroesophageal reflux to COPD exacerbations. And I've been a pulmonologist, pulmonary critical care doctor in town since 2009 when I started this private practice that we're at. When COVID hit us last year in 2020, and it really hit New York hard, I volunteered my time as a critical care doctor at Elmhurst in Queens, which was the epicenter of the epicenter, and spent a month volunteering as a critical care doctor. And since then, in addition to taking care of patients here in town, I've also spent my time for a week a month in Texas in the COVID ICU there as a COVID ICU attending physician taking care of COVID patients. So I'm here today to answer questions and try and see if we can help the community to understand this terrible virus.
Thank you, Dr. Pamer.
Sure.
So let's talk a little bit about variants. We've had 4 prevalent variants that I'm aware of. I'm not a doctor since this whole pandemic started: Alpha, Beta, Gamma, and now Delta. Can you tell us a little bit about what a COVID variant is, as opposed to the original COVID-19 virus?
Absolutely. So the variant is some genetic difference between the viruses. So we started with the wild strain, the initial strain of COVID when it came over here. But the way that a virus works is it gets into the cellular machinery and it makes our cells make virus as a manufacturing plant. And the more that it does that, and these billions of turnovers and these little copies, is of course there can be transcription errors. I can't even use, my dragon speech without finding errors. And, here we're talking about cellular replication, billions of times. Of course, there's going to be errors. Some of those errors result in viral production that's useless, and the virus does nothing. But unfortunately, some of those errors result in a virus which is far more transmissible and far more deadly. And when that happens, then we've got a variant which is a bigger problem, which is what we're dealing with now. Uh, the nomenclature of these viruses was a bit of a challenge early on. I think most of us would recall that they were talking about the B11 this or that, and people would talk about all these different these scientific names, and who could remember which strain was which? So a couple of months ago, thankfully, these have been renamed to the Alpha, the Beta, the Gamma, and now the Delta. It's important to remember that the initial COVID virus, we'll just call that the wild type. Then we had the Alpha variant, which showed up in the United Kingdom, and it turned out to be a more virulent, a more infective strain. And we had the Gamma, which showed up, which was out of South Africa, and that also appeared to be a more virulent strain and possibly more deadly. We had the strain from Brazil, which came up, which had some genetic mutations. We weren't quite sure how meaningful that would be. And now we're dealing with the Delta strain, which was discovered in India a number of months ago. And the problem that we have with this Delta variant, this Delta strain, is that it is far more transmissible. By a factor of 2 or 3 times, it's more likely to infect people. And we've certainly seen the effect of that as the prevalence of this virus has been explosive, as it started in India and then it moved to the United Kingdom and into the Middle East, and now it's here. And just to give people an idea, in late May, the Delta strain represented about 1% of the COVID viruses that were in this country. 3 weeks later, by early June, it was 6%. That's a 600% increase in just 3 weeks. And now, at this point in late July, it's up to 87% of the circulating strains. which is just an astronomical increase due to the infectivity of this virus. And further, it's paying attention to the younger people and the people with less risk factors and infecting them, and it's infecting people who've even been double vaccinated. Although the presentation's a little different, but this is a significant variant.
How protective are the vaccines against the Delta variant?
Good question. So the vaccines have been in development in one form or another for a long time. That's the first thing that I want to point out about that, because although you didn't ask me, there's of course feedback from people online and social media, which where they say, oh, this stuff was invented overnight or it was rushed into production, and nothing could really be further from the truth. Students of history will remember that it wasn't but 10 plus years ago that we had SARS, which had come over from China, and that was a coronavirus, SARS-1, where there was the virus jumped from a species, I believe it was a bat, and it became infective in humans, and it was it was a deadly strain. And when the initial SARS had come out, there was a lot of research that was done to try to develop a vaccine and understand the pathophysiology of that. And quickly they found out that there was a spike protein which was responsible for the way that it got into the cells. And so viral vaccine work began early on, over 10 years ago, against the spike protein. But then SARS kind of went away, so everything went on hold. The next coronavirus came a number of years ago, and it cropped up in the Middle East. Seems like the virus had mutated from a camel over into humans, and that virus was horrible. It had a 40% mortality in the humans that it infected. And again, since they had the backbone of the coronavirus vaccines and the spike protein, it started back up again. MERS, which is what it was called, Middle Eastern Respiratory Syndrome, was so deadly it burned itself out, and the vaccine work got put back on the shelf. Well, now here we are in 2019, and SARS has made a return. It's been labeled the SARS coronavirus number 2. And so we've named it COVID-19 because it was discovered in 2019. But the point in that slight history lesson there is to say that all of the work towards the spike protein had already really been done from a long time ago. And so the scientists were able to utilize that to their advantage quickly. And so initially the vaccine work began, and of course by Pfizer, by a number of companies, and the ones that we have licensed here, or perhaps license isn't the right term, the ones that we're using in the United States are Pfizer, Moderna, and then the Johnson & Johnson vaccine. And so when you say, well, how effective are they? I wanted to give that first thing about the background of them. These were studied in an enormous number of people. Between Pfizer and Moderna and then the Janssen, that's 120,000 people that it was studied in, roughly 40,000 in each one of those three. And those were split between those who were vaccinated and those who weren't. Awful. It's a large number of people. And then further, the Israelis studied it in 560,000 people who were vaccinated and 560,000 people who were not. I mean, it's over 1 million people. It's a huge number. And since then, also the British have studied it in 9,000 healthcare workers, and it's been studied and studied. And I can't think of any drug which has been studied in over 1 million people. So definitely we've got good numbers on this. So you say, well, how effective are they? And so what the initial data was shown as far as the Pfizer and the Moderna was compared to reduction in all COVID cases. And what was found was there was a 95% reduction in COVID cases in the vaccinated group in the Pfizer, and a 94% reduction in COVID cases in the Moderna group, which were phenomenal numbers. And then in the Johnson & Johnson vaccine, well, you look at a 66% reduction in the Pfizer and the Moderna were apples, and the Johnson & Johnson was an orange. In that, the Pfizer and the Moderna was a reduction in all COVID cases, as opposed to the Johnson & Johnson looked at reductions in moderate to severe cases of COVID, which would result in hospitalization. Very different number. And there was a 66% reduction in that. Although there is geographic variability with the J&J, whether you're looking at efficacy in Europe or the United States or Brazil, etc. But these are very, very effective vaccines. Now, in regards to our discussion today as it relates to the Delta, well, how significant, how effective are these vaccines against Delta? And unfortunately, they don't appear to be as effective against Delta. Now, the data is primarily with the Pfizer vaccine. As I said, that had a 95% reduction in infectivity in cases. I'm sorry, early on. But now, so the data on Pfizer as it relates to the Delta is not as promising. With one shot of the Pfizer, it perhaps might be in the mid 30% range effective against Delta, which is terrible. But at least in the double vaccinated people in the Pfizer, then there was a mid 80s to high 88% reduction in COVID cases, which is less than 95, but still a pretty good amount.
Mm-hmm.
And so what we've really kind of seen there is that with the increased infectivity of Delta, it's of course been an explosive. We know this locally, but it's also infecting people who have already been vaccinated. A little bit of a different presentation. And the people who had double vaccination or full vaccination against COVID, when they do get the Delta strain, they're more likely to get head cold symptoms of runny nose and fever and run down and the muscle aches, but it goes away after a couple of days. Versus when it's infecting the unvaccinated, then they're getting the traditional COVID destructive disease that we're all well aware of. And it seems that it's more effective now, of course, in the younger population who are less likely to be vaccinated, but it is certainly still infecting those who are double vaccinated. Looking now at the people who are hospitalized, unfortunately, 97% of them, and in some studies, 98.9% of them, are the unvaccinated group. It's very unlikely that should you get full vaccination, that even if you were reinfected with COVID or got your first COVID infection, it's very unlikely that it would result in hospitalization or death.
What can we take from our neighbors overseas and learn from them, and what have we learned from them, and what are things that we might see that we'll begin to apply here that they've already begun to apply?
Yeah. So this Delta strain that we're talking about was first noted in India, and it was seemed to be a much more explosive strain, which was far more easily passed, more easily to infect people. And so it moved through India very rapidly. I think all of us recall that from the news. But then it moved very quickly into the rest of Europe and up into England and down into the Middle East, where we were seeing there the same thing we're now seeing. I mean, we've looked across the Atlantic and we're seeing the same thing that they did. We knew this was coming, and unfortunately, it was coming at the same time that we had lax restrictions. Because we were seeing lower numbers. So that's a separate discussion. But talking about that infectivity, I think it kind of ties into something that the Israelis are doing now, which is with booster shots. We have to look at how long is the immunity that's induced by the vaccination. And that requires just a slight explanation on virology and immune functioning. So when we're infected by something, our first immune globulin that we make, which is an antibody, an immune globulin, is immune globulin M, IgM, and we make that pretty quick, but it goes away fairly quick. It's non-specific. But then we make this long-acting antibody that hopefully lasts for decades, and that's called IgG, immunoglobulin G. I wanted to see if you've been immunized, whatever, infected, let's say by polio or smallpox or hepatitis, you name it. I'm going to check the IgG level, the immunoglobulin G level. And as I say, sometimes those antibodies can last for decades, but sometimes they don't. And that's a problem that we may have to face here with COVID. It turns out, data published last year, is that the half-life of IgG is only 34 days. You say, well, wait a minute, what's a half-life? A half-life is the time it takes for half of something to go away in chemistry, a 50% reduction. Generally, the half-life of some of these immune globulins could be in the years or sometimes in the months. But here we're talking about 34 days. Well, in 5 half-lives, then it's gone. 5 half-lives at 34 days per half-life is 170 days, if I did my math right. 6 months. So we were concerned early on that, gosh, if that's true, where are we going to be 6 months after infection? Will there still be protective immunity? Where are we going to be 6 months after vaccination? Will there still be protective immunity? And I think many of us have been concerned about that, but really didn't have much clinical data to suggest where we would be. And further, it has to be said that IgG antibodies is not the only form of immunity that we have. We have other types, cell-mediated immunity, et cetera, which may have, we were concerned maybe that would carry the day. It wouldn't be so much IgG related. Now, that said, the 6-month thing has turned out to possibly be relevant. What the Israelis found was that after 6 months, they were noticing decreased immune activity against COVID in the vaccinated public, or even the people who'd had natural infection. And so, in order to protect their public, they've taken the proactive step to look at the patients at risk for severe COVID, the immune suppressed patients, and to go ahead and give them booster shots, which seems to make sense to try and keep their immune titers high and protect them. Now, we don't have data for that yet in the United States. And so there's no official recommendation yet as to whether or not we'll need boosters. I get this question all the time, and I try to answer it concisely for patients. We don't have the data yet. Now, Pfizer apparently has some data that they're climbing through, and that'll be supplied soon. And I suppose that we will hear at some point in the next coming months whether boosters are going to be required. I think the answer for that is going to be an analysis of the data, as well as looking at the infectivity rates in the vaccinated, the unvaccinated, and see what happens, whether or not we really need boosters, or just to hurry up and finish getting people vaccinated, which really would be the best answer in order to squash this curve and stop the infections.
All right, let's reel this back home now. Talk a little bit more about local. So in St. Lucie County and in the city of Port St. Lucie, our current positivity rate is 19.7%. That's as of this Tuesday, July 27th. New infections in St. Lucie are 1,054 this week. These are both indicators that we watch to kind of see how serious COVID is in our community. And both of these are pretty serious. I mean, over the past month, along with Delta quadrupling over the past month, the prevalence of Delta, these indicators that we're looking at have also gone way up. I mean, positivity, which is like how many people that get tested are positive. The positivity rate a month ago was, 5 weeks ago, was less than 5%. That's a safe zone. In that last 5 weeks, we're already up, hovering at around 20%. Very high, very dangerous. So based on our climbing numbers, what can we do to protect ourselves? What would you recommend?
Well, we know what to do to protect ourselves. We vaccinate. We try to stay away from other people. We called it socially distancing, but we try to stay 6 feet from people. We had early data that showed 3 feet of distance resulted in an 87% reduction in viral transmission, and it relatively doubled at another 3 feet. That's where the 6 feet came from. That's old data from when this first happened. So we try to stay away from people so that if they sneeze or there are respiratory droplets, that it doesn't reach the other person. And that brings into the masks as well. Now, ideally, everybody would have an N95, but that's not really going to happen. The N95s had shown in some studies a 96% reduction in viral transmission. Surgical masks had shown an 87%, a 67% reduction in viral transmission. But that's a real surgical mask, not the little flimsy masks that most people are getting at Walgreens or CVS or anywhere else. There isn't as much data on those masks. There's certainly not data that I'm aware of for COVID, but there is data for all bacterial infection, or for all bacterial infection for some viruses. Those masks have shown to reduce infectivity in older data. So I think the answer really comes down to the same social distancing, the same masks, and certainly the vaccinations is what we need to slow down the spread here. And I have to say that we knew this was coming. There is no one among us who should be surprised that we're seeing this explosive increase in COVID at this point. It wasn't but just less than a month ago that really we've had to push to open up the doors, get back into the restaurants, get back out into Publix. We just had 4th of July with thousands of people congregating together. We're out there, we're dealing with a 50% vaccination rate for the country, which is woefully short of that needed for herd immunity, estimated to be at a minimum of 70%. And so with all that, you could have estimated that, well, gosh, we're probably going to see an increase in COVID. And there at the same exact time, worst possible timing, the Delta strain arrived, which was far more infective and moving through the community like wildfire. So this was predictable. And I don't think anybody should be surprised, but I think we should all be disappointed that it's happened because it was preventable. If you ask me, I think we have to go back to masks, we have to go back to social distancing, and we've got to promote vaccinations because that is the key to reducing the transmission of this deadly virus. People have asked me, well, regarding the masks, do I have to wear one? And I say, well, I think that you should at this point. Now, some official recommendations from the CDC have come out even just recently in the last week, which suggested in an area of high infectivity or high prevalence, which we're at. You pointed it out. We've gone from 5 to 20%. That in these areas of high infectivity, that inside buildings, people should be wearing masks. And so I've been promoting that to patients as well. If you're outside and you're not around anybody, there's no point in wearing a mask. But if you're inside around other people, it makes sense to protect yourself and protect others. And following up with that, what happens if you're double vaccinated, and you come across somebody or you're exposed to COVID again? What happens? How protected are you? We've sort of answered that question already. If it was the regular COVID strain and you're fully vaccinated, you have up to a 95% chance of not getting infected. But with the Delta, it is lower. The people who are getting infected, as I said, who are fully vaccinated, seem to get head colds, although some still get the full-blown COVID. And I myself have had a patient just last week who's double vaccinated. She had risk factors, but she was double vaccinated and she passed away from COVID. And it's tragic that happened, but that is really the rarity. Up to 98% of the hospitalizations now are in the unvaccinated group. But my point here was, if you are fully vaccinated and you come across somebody, you're exposed to COVID, what should you do? And the reality is, you should put a mask. You probably should have been wearing a mask to begin with, but you should put a mask back on, because the chances you may get reinfected, especially with this Delta strain. And we know that you're going to shed virus before you become clinically obvious, before you're symptomatic, and that usually occurs within 3 to 5 days. So we're sort of recommending at this point, wear a mask, probably quarantine, socially isolate for at least those 5 days. Get tested. You really want to know if you've developed COVID, whether you've been vaccinated or not. If you're not positive after 5-6 days, then you're probably not infected, and it's okay not to quarantine at that point. But until further notice, until the numbers get back down to where they were before Delta, then we should be wearing masks when we're inside.
Thank you, Dr. Pamer. That gives us some, we see the problem. It's a big problem. It's pretty scary right now. But the good thing is we have things that we can do. Last year at this time, we had very few tools in our toolbox. We had 3, right? We had wear a mask, social distance, and practice good hygiene, right? Wash your hands, don't touch your face, etc. Now we have another tool, like the power tool, that we can add to that toolbox, and that is get vaccinated. So getting vaccinated, wearing a mask, practicing social distancing, and keeping good hygiene while this Delta variant is raging would be a recommendation for all of us to stay safe, stay protected, and stay out of Dr. Pamer's office.
Yeah, that's absolutely right. In order to protect ourselves and slow down the rate of this, we've got to get vaccinated. And you got to really be safe and stay away from other people and wear a mask inside when it's disinfected. And something I don't think we really touched on as far as the vaccinations is, I think we're at about 50% now of the national the population being vaccinated. Some communities lower, some higher. Do the vaccinations really slow down the rate of infectivity? I mean, absolutely. Nobody should be debating that. In the states which had the lowest vaccination rates, well, they seem to have the highest case rates now of COVID. Florida's leading the nation at 20%. Vermont has the highest vaccination rate. Just as of 2 weeks ago, they only had 11 cases a day, which is much lower than what we're dealing with. But this low vaccination rate carries some consequences which are significant. And that is, if you're unvaccinated, you are now the target for COVID, for the coronavirus. It has gone through a significant number of that older population with all the comorbidities. There are still a ton of them around, but prevalence-wise, the virus is more likely now to infect those unvaccinated people who tend to be younger and don't have as many of those risk factors. And that is exactly what we're seeing locally and nationally in the hospitals, is that it's younger people who don't have the comorbidities, who are getting sick, who are ending up in the ICU, ending up on mechanical ventilators, and therefore facing mortality, which they don't really need to. And that's really the tragic part here. We've got to finish the vaccinations. We've got to. It's the best tool that we've got, as you said. It's the power tool, and that's really the take-home point. Get the vaccine. It is safe. It is effective. It is well studied, and it is what we need to do.
I'd like to thank you, Dr. Pamer, for your time and the use of your office. We appreciate you very much in our city. Thank you, folks, for tuning in. Hopefully you learned something, and hopefully, we'll be through this very soon, and it'll be a distant memory.